Of our whole month, this week's topic that I'm doing my oral presentation on is polydactyly. So, what is polydactyly? Polydactyly is classified as a supernumerary digit on the hands or feet. So basically, an extra digit. So polydactyly is also known as hyperdactyly and is the most common hereditary limb anomaly characterized by extra feet or toes, and it has various associated morphologic phenotypes as part of a syndrome, or it may occur in a separate event. So if it occurs with the syndrome, it's called syndromatic polydactyly. But if it occurs kind of random or on its own without the child having any other syndromes or associated causes, it would be considered a non-syndromatic polydactyly. Polydactyly is among the most common congenital limb anomalies observed immediately at birth, and it manifesting in a variety of forms, ranging from complete to incomplete duplication of the digits. And its occurrence rate is 1.2 out of 1,000 births. To really understand polydactyly, I guess we must go back to what causes polydactyly and when in embryo does it occur. In humans today, we have 10 loci or 6 genes that are cause polydactyly that have been identified. Some of those genes would be like the GLI1 or the GLI3, also the sonic hedgehog gene, or even your IQCE gene. During embryogenesis, the identity and numbers of digits is controlled by a specific mechanism that initially polarizes the limb uh, primordium, followed by specifications of digit identity and growth regulations. There will be molecular clues in the genome that states if the limb primordium is polarized, for example, the GLI3 or the HAND2 genes. The limb primordium the very is the very first indication of a developing limb in embryo. So it consists of mesenchymal core originating from somatic layer of the lateral plantar mesoderm, and it is covered by ectoderm. So the lateral plantar mesoderm later goes on to form the bones and the connective tissues um, of the limbs. And then also the sonic hedgehog gene plays a huge role and is essential and crucial because it helps regulate the spatial variation among the anterior posterior axis. And it is a product of the zone of proliferating activity, so the ZPA, which is a group of mesodermal cells in the posterior segment of the limb. Experiments show that whenever the ZPA or the zone of polarizing activity is transplanted to the anterior segment, the sonic hedgehog gene secretion follows, thus resulting in an extra digit formation. So that was really cool to kind of do some more research on that and like expand my knowledge on that, and the embryogenesis of why polydactyly is around. So polydactyly can be associated with different syndromes or deformities such as Down syndrome, Lawrence-Moon syndrome, the ectodermal dysplasia trisomies 13 and 18, and it can also be genetic, and it's seen in 30% of newborns that have a positive family history for polydactyly. Classifications of polydactyly. So there's 3 that I saw covered largely for the foot. Obviously, there's more for the hands, but in the feet, there's many classifications that exist to help classify and organize the information. So the first classification that we have is Tentanomy and McCusick classification, which is classified as preaxial, which involves the hallux, central, which involves the digits 2, 3, and 4, and postaxial, which involves the 5th digit. So the preaxial is usually seen, according to our Watson manual, is usually seen in 15% of cases, while the centrals is in only 6 of cases, and the postaxial being the most commonly seen on 79% of cases. This classification, the Tentanomy and McCusick classification, will be further subdivided into type A and B. Type A meaning there is a well-formed articulated digit, and type B meaning that it's a rudimentary, often without skeletal component digit. So type A is a full-on extra digit with bone, um, and type B is just kind of like the soft tissue sticking out, making it look like a digit. There's no like bony attachments basically. The second classification we have is Blount and Oleson, which is another polydactyl classification which helps describe the position of the duplication in both the longitudinal and transverse planes. The longitudinal type describes the degree of duplication of the ray from distal to proximal with a division into 5 different types. The longitudinal type is further subdivided into 5 types such as distal phalanx, middle phalanx, proximal phalanx, metatarsal, and tarsal. The transverse plane indicates which rays are involved in the duplication. So it's pretty like self-explanatory. Then the third is Venn and Watson, and so Venn and Watson is based on the degree of differentiation, such as a Y metatarsal head, a T-shaped metatarsal, a Y-shaped metatarsal, and a complete duplication. Lastly, we're going to discuss the treatment for polydactyly. So, polydactyly treatments can vary from a simple one-day procedure to a more complex or multiple procedures that involve ligaments, tendons, and bones. So usually if it's a type of polydactyly, a type B that has no bony attachment or anything, and it's just kind of like fat and skin, they'll kind of tie it off to cut the blood circulation, and that will kind of just make the toe fall off. Um, but they have gone, I have seen them gone in there and to remove the bone, make sure it's not like sticking out or anything, causing any further defects, and then closing up the wound again. So there's also been research that states that it doesn't really matter when you do the surgery. So commonly you'll see the surgery done in approximately like if they're born with it, usually around the age of 1 or right before 1. This is obviously due to the 6 to 9 month gap we have to wait for anesthesia purposes to put a baby to sleep. But there's research that shows there's no ideal age for this. Sometimes we just kind of let the deformity play out, and you could see um, kind of the gait and mechanical factors that an extra toe will kind of cause the patient. Um, but I personally have a niece that was born polydactyly, who's never seen in the family, and she had surgery right before her first birthday. She healed nicely, and there's no further complications or shoe gear irritations or anything like that. So I recommend doing the surgery earlier than uh, earlier the better, I guess, to help prevent any gait issues later on down the road as the child grows and starts to walk.